Hello, my name is Dr. Wayne Weart. I'm professor of clinical pharmacy and outcome sciences at the Medical University of South Carolina, where I'm also professor of family medicine at MUSC. Been there for 36 years, and I probably know many of you, and I'd like to welcome you to this presentation that we're going to talk a little bit today about what can we do to make a difference for our patients when it comes to cardiovascular disease here in South Carolina. Cardiovascular disease is one of the leading causes of death, and we know that if we pay attention to blood pressure and cholesterol, we can make a huge impact on reducing the risk of cardiovascular disease and stroke here in our own state. So we want to share with you today the evidence for what drugs will make a difference in morbidity and mortality with our patients. And we want to do that in a cost-effective manner so that our patients can afford the medications. We want to make it simple, easy to take, once-a-day therapies, and we're going to review that evidence in this first presentation. So we're going to start for the next 20 to 25 minutes and review with you the evidence for treating high blood pressure and the evidence for treating cholesterol. At the same time, cover the current guidelines that have come out within the last year as well. Let me begin by letting you know that I don't have any disclosures. I do not speak for or consult with any pharmaceutical companies at this point in time. We're going to start with the new goals for blood pressure. In the last year, we have seen quite a few different publications with what should our goal blood pressure be in order to treat our patients to goal, what level should we shoot for? And JNC8 came out last year in the Journal of the American Medical Association, and in general recommended a goal blood pressure less than 140 systolic and less than 90 millimeters of mercury diastolic, with the exception of those patients who are 60 years of age or older, where they actually suggested less than 150 over 90. And these included patients that used to have even lower goals, patients with diabetes mellitus and patients with chronic kidney disease, where the old goals were less than 130 over 80. They are now back to less than 140 over 90, according to the experts from JNC8. Now, JNC8 was unlike JNC previous, because JNC8 was not reviewed by other organizations, and in general, the experts published their findings independent of any organization. It is not sponsored by the National Heart, Lung, and Blood Institute like it had in the past. So in general, most people agree less than 140 over 90. Where the controversy comes in is patients 60 to 79 years of age, when not even all the experts on JNC8 agreed with less than 150 over 90 for those patients. So they actually published a separate minority report that was published later in Annals of Internal Medicine in patients aged 60 to 79. They also believe the goal, if tolerated, should be less than 140 over 90, not less than 150 over 90. However, both agree when you're 80 years of age or older, a reasonable goal is less than 150 over 90. We also had, shortly after that, the American Society of Hypertension and International Society of Hypertension came out with their revised guidelines, and they also agree with a goal of less than 140 over 90, including patients with diabetes, chronic kidney disease, and coronary artery disease. They further agree with less than 150 over 90 as initial goals for patients 80 and above, unless they have kidney disease or diabetes, where they again consider less than 140 over 90. They further state that if you can achieve lower blood pressures, less than 130 over 80 in younger adults, and they don't have symptoms, you don't produce hypotensive symptoms, then again, that is a reasonable goal for younger patients with uncomplicated or complicated hypertension. The goal diastolic less than 90 actually comes from this trial. The Hypertension Optimal Treatment trial that was published back in 1998 in Lancet compared 3 different goal diastolic blood pressures. Diastolics less than 90, less than 85, and less than 80. And you can see across the bottom here, major cardiovascular events, heart attack, stroke, cardiovascular mortality and total mortality were not significantly different between the three goal diastolic blood pressures. And this is where the diastolic goal of less than 90 comes from all the evidence-based recommendations we currently have. This was left over from JNC 7 because JNC 8 really did not talk about the compelling indications that were included in previous editions. So patients who have systolic dysfunction or reduced ejection fraction heart failure or even preserved ejection fraction heart failure, the goal blood pressure should still be less than 140/90 according to the current guidelines. And the therapies that we have that are evidence-based, at least for reduced ejection fraction, are ACE inhibitors in full doses, angiotensin receptor blockers, especially for ACE intolerant, 3 evidence-based beta blockers, or an aldosterone antagonist like spironolactone or eplerenone. Thiazide diuretics are listed, but they are for symptom control. They have not been shown to reduce morbidity and mortality. So the 3 evidence-based classes currently would be ACE inhibitors or ARBs, beta blockers, and aldosterone antagonists. And what you see here on the right-hand side, the basis of the clinical trials, the guidelines, as well as the trials that were used for this evidence-based recommendation. If you've had a patient who's had a heart attack, a beta blocker at least short-term for 2 to 3 years, ACE inhibitor, and with new data, you could also say we do have one study with an ARB if you're ACE intolerant, and again, aldosterone antagonists have been shown to reduce morbidity and mortality in patients with hypertension who are post-MI. And again, we have the guidelines referenced beside. High cardiovascular risk patients, those at risk for coronary artery disease, we have good data from the ALL-HAT trial with thiazide diuretics, specifically chlorothalidone, a long-acting thiazide. We have good data for ACE inhibitors from HOPE. We have data for an ARB from the LIFE trial, and we have data for calcium channel blockers. What we don't have good data for probably is beta blockers, and they're not going to be in most of the newer guidelines unless you have a clear indication. For patients with diabetes, if we look at the guidelines from the American Diabetes Association, the American College of Clinical Endocrinologists, the ACE guidelines, they all would say an ACE or an ARB would be their first-line therapy. Noting, however, based on a recent meta-analysis, ACE inhibitors actually appear to have better outcome data, reducing cardiovascular events in patients with diabetes than ARBs do, and the guidelines do not routinely recommend the combination of an ACE with an ARB, one or the other. You can also use a thiazide-related diuretic. They are fine in patients with type 2 diabetes and evidence-based. You can also use a calcium channel blocker, the ones that are most evidence-based, again, amlodipine, a longest-acting dihydropyridine, and there was some original old data with beta blockers, but again, they're probably not our go-to therapies unless there's another indication. Patients post-MI, the patient has angina, the patient has atrial fibrillation for rate control, then beta blockers are fine in patients with type 2 diabetes. Chronic kidney disease, ACE or ARB, again, one or the other, probably not the combination. And this is consistent with the National Kidney Foundation guidelines. We have great data that ARBs and ACE inhibitors reduce the risk of developing end-stage renal disease, reducing the need for dialysis, kidney transplant, and some degree, with ACE inhibitors at least, they reduce cardiovascular events in these patients. And then patients post-stroke, thiazide-related diuretics, specifically indapamide is the one that has the best data, the old Losol, in combination with an ACE inhibitor based on the PROGRESS trial. And if we look at what we can do to reduce the risk of recurrent stroke, it's controlling blood pressure with an ACE plus a thiazide-related diuretic. We can use aspirin. We can also use other antiplatelets in appropriate patients, as well as full-dose statin therapy for reducing the risk of recurrent stroke. But blood pressure is key to control to reduce the risk of recurrence. This is where the data comes from for the goal blood pressure less than 150/90 for patients 80 and above. This is a HIVET trial. This is a trial that was done with over 3,800 patients who were at least 80 years of age or older, actually going up to 100 plus years of age. But I want you to remember that these patients were all relatively healthy, free living. These are not patients that are in nursing homes. These are not patients who are debilitated for the most part. These are patients that have a good quality of life that were recruited for this trial. And they were randomized to a sustained release dose of indapamide or placebo, and the mean follow-up was only 1.8 years. They stopped the trial early. All stroke was one of their primary endpoints, and it reduced the risk of stroke by 30%, with a number needed to treat at 2 years of 94 patients to prevent one recurrent stroke. Death from stroke was also reduced, with a number needed to treat for mortality at 2 years of 40. So this is where we get the goal, less than 150 over 90, and it's the only trial that I can share with you that looked at patients from 80 to 100 years of age. And the drug that was used was indapamide, which is a thiazide-related diuretic. And if they didn't get to goal, they could add an ACE inhibitor to it in the HIVET trial. This is a trial that has changed some of our minds as far as where do we go first versus second line therapy in patients with cardiovascular risk factors. This is the ACCOMPLISH trial. And ACCOMPLISH was a large multinational double-blind trial in 11,508 patients that was actually to compare two different combination therapies. The one arm was an ACE inhibitor, benazepril, titrated to 40 milligrams a day, and if they didn't get to goal, they could add a thiazide diuretic, hydrochlorothiazide, could be added to it. The other arms also started with benazepril, the ACE inhibitor, titrated to 40 milligrams a day, and if they weren't at goal, they could add amlodipine, a dihydropyridine calcium channel blocker, and a target dose of 5 to 10 milligrams a day. The primary endpoint at the end of this trial, which the mean duration was 36 months, with a goal blood pressure less than 140 over 90, was to look at cardiovascular morbidity and mortality. So the primary endpoint was reduced by 21% in the patients who got a calcium channel blocker added to benazepril ACE inhibitor, as compared to adding hydrochlorothiazide to the same ACE inhibitor at the same dose. So the absolute risk reduction was 2.2%, which leads to a number needed to treat to prevent one cardiovascular event or death of 46 patients. And if you break it out into men and women, they both benefited. Number needed to treat in men was 40. Number needed to treat in women was 63. If you look at patients with diabetes, and almost 2/3 of these patients had diabetes at baseline, number needed to treat is 46, and if they didn't have diabetes, 48. There was also a significant number of patients in this trial that were 65 or 70 or greater years of age, and their number needed to treat if they were 70 or above is 36. So all the subgroups had a significant greater reduction in cardiovascular morbidity and mortality if they received an ACE plus CCB than the same ACE at the same dose plus hydrochlorothiazide. Secondary endpoint, systolic blood pressure, was significantly reduced over time with both treatments, and both treatments reduce events, but it looks like the ACE CCB is more effective by 21% at reducing the endpoints that make the most difference, cardiovascular events and mortality. So here is the table again with men versus women, numbers needed to treat. Over 65, over 70 diabetes, no diabetes, and again you can see the characteristics of the patients in the trial. We saw an eGFR less than 60 and 18%, and the renal endpoints were also beneficial, more so with the ACE-CCB than the same ACE and hydrochlorothiazide. So here's the renal outcomes. Progression to chronic kidney disease primary endpoint was again reduced with a number needed to treat at 57, with ACE-CCB being better than the same ACE plus hydrochlorothiazide. Doubling of serum creatinine, number needed to treat is 57. There was no difference in dialysis, although there was a trend slightly lower with the ACE-CCB. eGFR less than 15, no difference. Progression and cardiovascular endpoints combined, number to treat 47 in favor of ACE plus CCB, and all-cause mortality, the same thing, number needed to treat of 50 at the end of an average of 36 months. So again, this is Dr. George Bacris in the article in Lancet. Dr. Bacris is a past president of the American Society of Hypertension and a nephrologist in Chicago. This is the algorithm that we are using for CCI when we look at what are we recommending. This is based on the UK NICE guidelines, the British Society of Hypertension, and it takes into account some of the studies we've just looked at. And it really breaks things down pretty straightforward. First, it looks at age. Under age 55 recommends an A or an ACE inhibitor or an angiotensin receptor blocker if they're ACE intolerant. If you're over 55 or African or Caribbean descent at any age, they start with a C, which is a calcium channel blocker, and we are recommending basically amlodipine as the most evidence-based, cost-effective channel blocker. If you're still not at goal, or if you need a 20 millimeter reduction or greater in systolic blood pressure, 10 or greater diastolic, we'd recommend you start with a combination. And that combination would be an ACE plus a CCB, or an ACE intolerant patients, we would recommend you use an ARB plus a calcium channel blocker. Step 3, if you're still not at goal and need to add a third one, then we go to a thiazide diuretic as step 3 instead of step 1 or 2. And the two diuretics that are most evidence-based, based on the data, would be chlorothalidone, 12.5 to 25 milligrams a day, or indapamide, 2.5 milligrams a day would be a target dose, and both of these are the most evidence-based thiazide-related diuretics. So that's step 1, 2, and 3, and then with resistant hypertension, we might consider adding a fourth drug, and the one that's been most studied, most interest in, would be the aldosterone antagonist spironolactone, as long as your potassium is not elevated and your renal function is not significantly impaired. You can see an alpha-beta blocker was listed in resistant hypertension, and beta blockers are not there for blood pressure unless there's another reason to use it. Again, your patient with angina, your patient with atrial fibrillation for rate control, your post-MI patient, maybe your migraine prophylaxis patient, you might consider using a beta blocker. This is an interesting data set that comes from the SELECT trial from the Journal of Clinical Hypertension about 10 years ago. And what it looks at is patients who complain of peripheral edema, swelling, mainly lower extremity edema, leg swelling, if they got the combination amlodipine plus benazepril, which is commercially available and generically available as Lotrel, as compared to amlodipine alone, the orange bar, 9.4%, or even benazepril, the ACE inhibitor alone, Lotensin, 5.6%. So you see the combination is less. And this is probably because the dihydropyridine channel blockers, like amlodipine, dilate the precapillary bed. And if you dilate the precapillary bed, what you're doing is increasing intercapillary pressure, and that's where the edema comes from. It's generally not as responsive to adding as diuretic as you might hope. So by adding an ACE inhibitor or an angiotensin II receptor blocker, in this case benazepril, you mainly dilate the postcapillary bed, reduce intercapillary pressure, and the edema is significantly less. So the recommendation, again, to reduce the side effect that we see commonly with amlodipine is to use it in combination with an ACE or an angiotensin II receptor blocker. This is the data from the HOT trial from the patients with diabetes. This is a diabetic subset, and this is where some controversy comes in for your goal diastolic blood pressure for patients with diabetes. Same study design. This is felodipine, and they could add enalapril if they needed to, and less than 90 diastolic, less than 85 versus less than 80. And you can see that the diastolic less than 80 appears to have better outcomes when it comes especially to major cardiovascular events and cardiovascular mortality, those are both statistically significant reductions as compared to 90 or less than 85. And this is why the American Diabetes Association has a goal less than 140/80 in their guidelines. And even the ACE guidelines say approximately 85 for the diastolic goal. This is the trial that kind of changed the guidelines for people with diabetes. This is the Accord blood pressure arm from the Accord trial. And they had two different goal blood pressures. They had a blood pressure goal less than 140 systolic and a blood pressure goal less than 120 systolic. And they didn't specify what drugs you could use. They allowed the investigators to titrate to these two goal blood pressure. And you can see the investigators did a pretty good job. Actually, the less than 140 group got to about 135, and the less than 120 group got to around 119 and maintained it for the duration of the trial. So you can see there's significant difference of almost 15 millimeters of mercury between these two groups maintained over the entire time of the trial. And here's their outcomes. Most of the outcomes are not significantly different. Lower was not better. The intensive group, the primary outcome was exactly the same, no significant reduction. Cardiovascular death, no difference. Non-fatal MI, no difference. Where there was a difference is in non-fatal stroke and total stroke. Again, blood pressure drives stroke more than most of the other outcomes. Lower blood pressure, lower the risk of stroke. So we did see that in the Accord blood pressure arm. But overall, cardiovascular risk, the primary combined cardiovascular endpoint, was not significantly lower with lower blood pressure. But you also see there was no increase in cardiovascular risk or mortality with lower blood pressures. So the goals for people with diabetes and hypertension in general from the ASH and from JNC is less than 140, and the ADA is now less than 140. Lower goals, less than 130, may be appropriate for younger patients as long as they can be achieved without significant burden or side effects. Patients should be treated to a diastolic pressure less than 80 according to the data from the HOT trial, and that's where the ADA still is, whereas the folks from JNC 8 and ASH would still recommend goal less than 90 millimeters of mercury. But again, you can see there's some room for difference here. The good news is that lower does not appear to increase the risk of any adverse outcome, at least in the range that we're talking about for these patients. This is the current ADA recommendations. Suggest there's association between an increase in sleep time blood pressure, those who are non-dippers that don't dip their blood pressure when they go to sleep at night, and that is seen more commonly in people with cardiovascular history, with sleep apnea, with COPD, and with patients with diabetes or chronic kidney disease. So the ADA has put in a recommendation to administer one or more antihypertensives at bedtime, and they actually give it level evidence A, their highest level of evidence, and it's based on one trial of 5.4-year mean duration of follow-up, and I'll share the results of that with you in the next slide. So this is the MAPEC trial that was actually published several years back, and MAPEC was a 5.6-year trial in over 2,100 patients who had hypertension, and it's a single center study from Spain, and that's why I'm a little bit hesitant to say I'd give it level evidence A. The mean age is 56. 20% of these patients had diabetes, and there was actually a separate publication in the journal Diabetes Care a year later that gave that data. There's also one in kidney disease patients, a separate publication in the American Journal of Kidney Diseases from this subset as well. And they were randomized to take all their medications upon awakening in the morning once a day, or at least one or more in the other group taken at bedtime. And the daytime blood pressure with both groups was about 125/75. So they both got, especially the diabetic subset, got to goals less than 130/80. Nighttime blood pressure was a little bit lower, 5/2 millimeters for the bedtime group as compared to the morning group, and mortality was also significantly lower, with the morning group 2.6% versus 1.1 with the other groups. So that's an absolute difference of about 1.5%. Number needed to treat is actually in the range of 65 to 70. And cardiovascular events also significantly reduced by a huge amount, over 10%, number needed to treat of 9. We also have some new data looking at adherence in patients with hypertension and medications that is from Quebec in Canada. It's a prospective cohort of almost 16,000 patients followed over quite a time period, and they found out 31% of these patients did not fill their first prescription within 9 months of when it was written. So again, it's a nationalized healthcare system. They know when the prescription was written. They know if it was filled or not, since it's covered under the same system. And basically, the drugs that were least likely to be filled by these patients were the most expensive medications. So cost was a huge driver, and 1 out of 3 prescriptions were not filled, even though it's a nationalized system where there are cost considerations and controls. This is a huge problem we need to address in managing our patients with high blood pressure. It's called therapeutic inertia. What that means is we have patients who come in and see us on return visits whose blood pressure is not controlled, and what do we do when we see those patients? And this data suggests we don't do a very good job at up-titrating or increasing the intensity of our therapies to get patients to goal. So this is a study that comes out of the American Journal of Managed Care and the Journal of Hypertension that looks at JNC7's recommendations. And if you have patients who have a systolic blood pressure of 150 to 159, 87% of those visits, no intensification was made to their therapy. If their blood pressure was 160 to 169, which is stage 2 hypertension, 79% of the time there was no intensification made. Even 170 to 79, 72%, and 180 or greater, more than half the time, there was no intensification of patients' drug therapy to get the blood pressures to goal. And these are the folks we really need to be addressing. And it may be they're not taking the first drug they've got. There may be lots of reasons, but we need to try and get to the bottom of why they're not taking their medications. So here is our guideline that we've come up with for CCI, and it's adapted from the NICE guideline as well as what we think is cost-effective, evidence-based. So again, we start by breaking it based on age, less than 55 or 55 and older. We consider Caucasians, non-African descent, less than 55. We start with a RAS blocker. So that's an ACE inhibitor or an angiotensin II receptor blocker if they're ACE intolerant. If they're of African descent or they're 55 and older, we recommend starting with a calcium channel blocker, and again a dihydropyridine for most, unless the heart rate is already greater than 80, then we might consider a non-dihydropyridine like diltiazem or verapamil. If they need more than a 20 millimeter drop in systolic, 10 diastolic, we'd start with dual therapy, an ACE plus a CCB or a RAS blocker, angiotensin II receptor blocker plus a calcium channel blocker. And again, in the Africans, we'd start with the calcium channel blocker and add an ACE or an ARB to the calcium channel blocker. Step 3, thiazide-related diuretic, could be hydrochlorothiazide, ideally would be chlorothalidone, 12.5 to 25, or indapamide. If they're still not at goal, then we would also consider adding an aldosterone antagonist or another potassium-sparing diuretic like moduretic or amiluride, as long as their renal function's okay, greater than 50 GFR, and their potassium is less than 4.6. We also would look at intensifying diuretic therapy. We could add a different or change diuretics. We could also add a second calcium channel blocker from a different class. We wouldn't add diltiazem to verapamil. We would not add diltiazem or verapamil to one of the cytochrome P450-3A4 metabolized channel blockers like felodipine because of drug-drug interaction. Amlodipine is the go-to dihydropyridine for most, and we could conceivably add verapamil or DILT, one or the other, not both, to amlodipine if we needed to. We could also add an alpha-beta blocker like carvedilol or labetalol, or we could add an alpha blocker sympatholytic. So again, we've got some other drugs we could add way down on the list, but most patients should be able to be controlled with steps 1, 2, and 3, and if necessary, adding aldosterone antagonists as long as it's safe to do so. The other thing that we have some new data, this was just published in August of this year in the Journal of the American College of Cardiology, and it looks at polypills. And polypills are not yet widely available in too many places, but they're being studied. And they combine blood pressure pills with antiplatelet drugs like aspirin with statins. They're combinations, typically of 3 or more medications that target cardiovascular risk in one pill. And what we have here is 3 trials, the IMPACT trial, the Empire trial, and the GAP trial, that all show if we use the polypill, the percent adherence goes up to between 70 and 85% versus about 50 to 60% with usual care, which means single pills taken with each drug. So multiple pills a day, 3 or more pills a day versus 1. So if we can simplify the regimen and maintain low cost, we can increase adherence and persistence, and that gives better outcomes. So this is one of the things that we're trying to see in the pharmaceutical industry, and the FDA are in the process of evaluating several of these polypills right now. So if we go back again and look at our single pill combinations we can use. For step 1, we have RAS blockers plus CCBs. We have a combination of benazepril plus amlodipine, the generic Lotrel, and it's on our preferred list for CCI and the buy low list. So it's one pill getting both drugs, and it comes all strengths for CCI patients. We could also theoretically then use a RAS blocker plus a diuretic. We have lots of those as single pill combinations. We can use hydrochlorothiazide, spironolactone, aldactazide as a single pill combination. We can use hydrochlorothiazide amelioride, diuretic as a single pill combination. So there are quite a few out there, and I think you'll find there are more to come down the road in the near future. The other thing that we have that suggests single pill combinations do a better job controlling blood pressure is the STITCH trial from Canada. The STITCH trial from Canada looked at over 2,100 patients from 45 solo practices in Ontario, province of Canada. And 27 used guideline care, and 18 the STITCH, or a simplified therapeutic intervention, control hypertension, which means they use single pill combination therapy in the STITCH group. So there are 4 steps. Initial therapy with a half tablet, low dose ACE or ARB diuretic combination. Up titration is step 2. Addition of a channel blocker, and up titration is step 3, and then addition of one of the non-first line blood pressure meds. And single pill combinations in the STITCH group versus guideline care, each drug was a separate tablet in the other group. So the results of the STITCH trial looking at percentage of patients who achieved target or goal blood pressure, significantly higher in the STITCH group, almost 65% versus about 53% in the usual care group, and that absolute difference was 12%, number needed to treat of 9 patients. So for 9 patients treated with the simplified approach using single pill therapy, titrated with that versus multiple drugs, we had 1 more patient get to goal. So again, single pill combinations do help achieve goal therapy. We also have not only the blood pressure side, but what do we do with cholesterol? We know that patients with cardiovascular risk, lowering blood pressure with selected drugs is important, and treating them with appropriate doses of statins is also appropriate. So we also have new guidelines from the ATP4, published by the American College of Cardiology and the American Heart Association, again last fall, and endorsed by most of the organizations that endorse guidelines. So this one was an endorsed guideline. So one of the things that's new in this guideline that's somewhat controversial, there's a lack of randomized controlled trials to support titration of a drug with a statin to get a specific LDL or non-HDL cholesterol goal. So these guidelines do not recommend titrating to a goal. They do recommend using an appropriate intensity statin therapy to reduce risk, so titrating to a dose rather than a goal lipid level. We'll come back to that in a minute. They also suggest that there are quantitative comparisons within statin risk, and non-statin therapies do not provide atherosclerotic cardiovascular disease risk reduction or safety profiles comparable to statin therapy. So they are not recommending that we go to non-statins, fibrates, niacin, the other drugs. We don't have as good an evidence they reduce events as we do with appropriate intensity statin therapy. So what they've suggested in their target groups to treat for secondary prevention, people with disease or an LDL greater than 190, we give these patients high intensity statin therapy unless they're over 75 years of age, and then we go to moderate intensity statin therapy. There are only two levels of intensity in the guidelines, high intensity and moderate intensity. For people with diabetes, both type 1 or type 2, age 40 to 75, the ADA is recommending a statin titrated to a target dose, moderate intensity for people without disease, and those who have a 10-year calculated risk with the new pooled risk equation greater than 75, or they're recommending moderate intensity unless their calculated 10-year pooled risk is greater than 7.5%, then they're recommending go right to high-intensity statin therapy. We show you a table with those intensities in a minute. For primary prevention, at patients age 40 to 75, again, moderate intensity, and their 10-year risk is greater than 7.5%, high-intensity therapy is recommended. Here's the table of intensity that comes right out of the guidelines. This was published in Circulation, and high-intensity therapy gives us a 50% or greater reduction over baseline LDL, and there are only two drugs that are listed with specific doses. What I want you to note from the slide is anything that is bolded, if the drug is in bold, that's an evidence-based drug, and the dose is bolded, is evidence-based. If it's not evidence-based, it is not bolded, and the dose is also not bolded if it's not an evidence-based dose. So atorvastatin, most of the evidence-based high intensity is 80 milligram dose. Rosuvastatin is only evidence-based at the 20 milligram dose, yet there is a 40 milligram dose on the market that would give you a greater reduction in LDL. It's just that it's not been studied in an outcome trial. Moderate intensity is where we have lots of choices. Atorva 10 or 20, Rosuva 5 or 10. You can see the 10 milligram doses of both of those are evidence-based. Simvastatin only now has max dose of 40 milligrams unless you've been on it for more than a year, and it is a moderate intensity statin at the 20 and 40 milligram dose, and both doses are evidence-based. Pravastatin 40 and 80 are moderate intensity. Lovastatin 40 is moderate intensity, Fluvastatin XL 80, and Fluva 40 BID, and pitavastatin, Livalo 2 to 4 are all moderate intensity statins. Low intensity should only be used if moderate intensity is not tolerated. So the specific statins and doses that were used in the trials. We also have some new guidelines by the National Lipid Association, just came out in October of this year. And while they agree with high intensity and moderate intensity statin therapy, their table is the same for intensity, they still want us to check goal lipid levels. And their primary goal, they suggest, would be non-HDL cholesterol, which is your total cholesterol minus your HDL. And that goal should be 30 points higher than the patient's LDL goal, which is their secondary goal now. So for people with risk factors, but low, be less than 130 non-HDL and less than 100 LDL, and they also put an optional goal as a secondary goal, ApoB levels less than 90. For moderate and high intensity risk, they don't change the goals. For very high, people with disease, their non-HDL goal is less than 100, their LDL goal is less than 70, and their proposed ApoB goal is less than 80. So these are the goals by the National Lipid Association, and again, they prefer statins as first line, titrated to full intensity therapy to get patients to goal. This was also a recently published cohort study in 2014 in Annals of Internal Medicine, where they looked at Medicare beneficiaries aged 65 and older with prescription drug coverage under Medicare Part D between 2006 and 2008 who initiated statin therapy. What they found is adherence to statin therapy is measured by the proportion of days covered, PDC, up to 1 year, and a composite outcome comprising hospitalization for all coronary syndrome and stroke and all-cause mortality were related to adherence. So what they found is over 90,000 patients who initiated therapy, 93% initiated a generic drug, simvastatin and atorvastatin, pravastatin probably being the three biggest ones, and 7% initiated a brand name drug. The average persistence was 77% for patients in generic group and 71% in those in the brand name group that was statistically significantly different. 8% absolutely greater persistence rate, and they also had a reduction in the rate of clinical outcomes, 8% in the generic versus brand name group. That was also statistically significant. The absolute difference was 1.53 events per 100 person years in the group that got generic statin versus branded statin. So again, cost is a driver for persistence and adherence, and if we can get people to take the drug, the better they take it, the better the events are when it comes to blood pressure and cholesterol. So that's kind of the evidence we're going to look at, and now what we want to look at is what are some of the examples that we can come up with that are cost effective to help our patients achieve these goals, get good outcomes, at the same time make them cost effective. And we promise that as new data comes out, CCI will keep you up to date on current options and therapies. There'll be some new therapies for patients coming with heart failure, with a new category of drugs, some other things, and we will try and keep you updated when those things come out. So please continue to refer back to ccihealth.org for any updates to this recording on a regular basis. And thanks for viewing part 1, and we will now move into part 2. Thank you for taking your time to watch these videos. This first one was evidence-based review of blood pressure and cholesterol, and part 2 will relate more to the cost and how we can achieve better outcomes through single pill therapies and using lower cost evidence-based medications.